Bismillah ar-Rahman ar-Rahim. First of all, I was thinking what to present as a grand round for ophthalmologists. I was thinking of emergencies that we are missing sometimes in the clinic. I was thinking to present something about medications in the clinic that can induce emergency situations, or situations in theater that we might face and we might not be able to treat well because it's rare. But at the end, I found that it's good to present something about acute acquired comitant esotropia. Little bit a difficult name, but we will go through and inshallah it will be easy. In 1958, Burian and Miller reported 5 cases of acute acquired comitant esotropia and described the 3 categorical features of it. And we will go through these 3 subtypes. Then a number of reports have added to this work, but most of these reports were quite limited. There remain a debate over its etiology, clinical features, and classification. In this lecture, I will try to describe its clinical characteristics, discuss its classification, as well as its relationship with neurological diseases. Dr. Ilham Al-Qahtani knows this person very well, and she had been trained with Professor Christopher Lyon, and he wrote a very nice paper, and he labeled it with a very nice title, Where the Wild Things Are When Esotropia Misbehaves. And I got these few words from his introduction. He said, esotropia is the commonest form of strabismus. It is the bread and butter of practicing pediatric ophthalmologists. As with everything in life, when its management is easy, it's easy. Every now and then, however, lives throw up a wrinkle in the otherwise smooth diagnostic or therapeutic process. And this is exactly what we would face in acute comitant esotropia. In general, when a child when we say esotropia, directly we will think about congenital esotropia or infantile esotropia or comitant esotropia. And as you know, infantile esotropia, also termed congenital esotropia, manifests before 6 months of age. And there is no accommodative component. Surgical correction is required to achieve proper eye alignment. On the other hand, the accommodative esotropia manifests between age of 1 to 3 years, and the proper eye alignment can be achieved with the spectacle correction alone. We have features of both classic infantile esotropia and accommodative esotropia, which can be seen in some infants and kids. Accommodative esotropia can be further classified to full and partial accommodative esotropia. We have a condition, sometimes we face it in the clinic. You have a child, you are following him for a while, he's a case of accommodative esotropia. Then suddenly you see him and he's having esotropia. You check your power, you check your refraction, and it's good. This is an entity called decompensated accommodative esotropia. And it's esotropia that no longer treatable with spectacle correction alone, and the non-accommodative component develops for unclear reason. The incidence has been reported as few as 2.4% and as many as 50%. Several risk factors have been suggested, including onset of the esotropia, if it had been there before 2 years of age, oblique dysfunction, greater esodiviation at near more than at distance. Now we'll go through our topic, acute acquired comitant esotropia. But we have another name in the literature which might confuse us, acquired non-accommodative comitant esotropia. In fact, the acute acquired comitant esotropia is part of this big title. But the difference we will try to go through, even though in the literature you will have a mismatch between the two, or sometimes they refer one to the other one, or they will label it as a same name. This subject has not been given very much attention in childhood esotropia and is usually given only a few short paragraphs, and sometimes it's not mentioned at all. Once thought to be rare condition. Jacob and colleagues proposed that acquired non-accommodative esotropia was perhaps not as rare as it's thought to be. And they identified 174 with this condition and determined that the number represented a prevalence of 1 in every 287 live births, which means this is not a rare condition. In another study, in a 3-year prospective study in a region in the eastern United States, esotropia was diagnosed in 221 children. 10.4% had acquired non-accommodative esotropia, and 5.4% had congenital esotropia. So it's double the infantile esotropia prevalence. Money in a 10-year retrospective cohort study of more than 600 cases of childhood strabismus found the following. The acquired non-accommodative esotropia was the third most common type, 10.2%. After accommodative, so the accommodative is the leading cause of 27.9%, and intermittent was the second, 16.9%, and the third was acquired non-accommodative esotropia. The congenital esotropia was the fifth, of 4.8%. So, which is which? Is it acquired accommodative esotropia? Is it the same as acute acquired? Is it the same as acquired non-accommodative? Well, acquired non-accommodative comitant esotropia, which refers to a group of conditions not associated with accommodative effort. Through the name, you know it. The onset can be the differentiating factor between both. If it is acute, most likely it's acute acquired comitant esotropia. If not, this is most likely acquired non-accommodative. If dramatic onset of relatively large angle esotropia with diplopia and minimal refractive error, as I said, this is most likely acute acquired comitant esotropia. The angle of esotropia is in acquired most likely can be quite large angle. A relatively low hyperopic refractive error. Patients with acquired non-accommodative are generally thought to have good binocular potential. The esotropia must be comitant in horizontal gazes, as the name is telling you, it's a comitant. Many patients complain of diplopia, or they will exhibit behaviors suggestive of diplopia, like squeezing one eye or avoiding looking in certain direction. The Jin Chang et al. List the following characteristics of acute acquired comitant esotropia. If it is concomitant non-accommodative esotropia with acute onset, diplopia or visual confusion, potential for normal binocular vision, and high favorable surgical outcome after the correction, and the deviation most likely more than 20 present, most likely happens above 5 years of age. So this is another important factor, and many literature, they mention the age of 5 or 6 years of age. No tendency for spontaneous resolution, so it will not be spontaneously resolute. But in the literature, diplopia was inconsistent feature in some reviews, and in several studies, it was reported during infancy and early childhood. So the age is not a cut for diagnosing it. You might have infant or early childhood patients with acute acquired comitant esotropia. Is it important to discuss this subject? I was asking myself, is it important? Yes, because binocular function is usually stable in patients 5 years and above, and if they develop esotropia, there is something happened that affected their fusion. So a reason need to be sought to know what is the cause of loss of fusion. This is a commonly benign condition, but children with intracranial pathology, particularly posterior fossa tumors, can present in this way. Only in this way. You will not find any other findings in the patient, neurological-wise or ophthalmological-wise. Only you will find esotropia comitant. The esotropia, acute acquired esotropia, had been classified to 3 forms, and this is since long time, as I said, since 50s. The first type was that occurring after artificial interruption of binocular vision. They label it as a swan type, after patching one eye, or after ptosis, if patient developed any acute illness like Claisian, or he had infection in the lid that causes ptosis, or you patched him because of an anisometropia, he might develop esotropia of the swan type. Type 2, acute acquired comitant esotropia, known as Borean Franchisti, is not associated with any known underlying etiology. Usually happen with diplopia, but good potential of binocular cooperation, and it may be intermittent at first. The third type is Belshewski type 3, and is associated with patients who are myopic, and the mechanism of action of this subtype have been postulated to be convergence spasm. Either those patients are myopic or they were treated as myopics and they are not having any refractive error. For example, a child who is having pseudomyopia and you give him the glasses as if he is myope, then he will develop a spasm and he will develop esotropia secondary to unneeded glasses. Von Norden labeled another type related to the intracranial pathology. If the patient is having intracranial pathology, Von Norden labeled it as a separate type. As I said, in group 1 and 3, we have a reason. We have interruption of binocular vision in the first type, and in the third we have accommodative spasm. So we have a reason for number 2 and number 3. In group 1 and 3, there is a generally clear cause for loss of fusion, and investigation is not indicated in the absence of any other abnormality. If there is no other abnormality, so most likely this is the cause. So you treat the cause. But in group 2, there is no clear cause for the breakdown of fusion, and there is a concern about underlying neurological cause. In Pouch and Vending, they found 7 cause-specific types of acute acquired comitant esotropia in their review. They found the acute accommodative accounts for 31%, so if the patient is having hyperopia and he's having a problem with the accommodation, it accounts for 31%. If there's decompensated monofixation, it's around 27%. Idiopathic, 19%. Intracranial disease, 3.6%. Occlusion-related, 3.6%. Secondary to a different etiological disease, 6%, and cyclic, around 4%. ومن يتق الله يجعل له مخرجا ومن يتق الله يرزقه من حيث لا يحتسب ومن يتق الله يجعل له من أمره يسرا ومن يتق الله يكفر عنه سيئاته ومن يتق الله يعظم له أجرا. In none of 174 acquired non-accommodative esotropia patients in Jacob cohort study was diagnosed with a central nervous system lesion during a mean follow-up of 1 decade. In 10 years, they were following large number of cases, and they didn't find any single case of central nervous system pathology. Lyon and co-workers in a prospective study around 3.5 years identified 10 patients with this condition with diplopia, and only 1 patient found to have central nervous system pathology, and it was astrocytoma. But in the literature, there are multiple case reports of children presenting with acquired non-accommodative esotropia or acute acquired comitant esotropia, and the initial manifestation was a brain tumor. There are many studies in the literature which state that intracranial lesion may present with acute acquired comitant esotropia without any other neurological deficit or other signs. What is the mechanism? Why those patients will develop esotropia if they have a brain tumor? Actually, it's not clear, but we have some people explain it, like Lindstrand, Hoyt, and Gott. They reasoned that the comitant strabismus might result from involvement of supranuclear mesencephalic structures which control the vergence eye movement. It's explainable if the patient present with incompetency, you might think that, yeah, okay, because it's incompetent, it can be explained. But why it's committant, this is one of the explanations. Jablonski and others have related to infranuclear insults, such as varying degree of bilateral sixth nerve paresis with the spread of comitants. The association of acute acquired comitant strabismus with brain tumor, 50% of posterior fossa lesions, they presented only with esotropia without any other signs. 50% of posterior fossa tumors. Patients with tumors of the infratentorial space may develop also esodeviation, and this is through primary interference with the pontine or cerebellar oculomotor control, or by developing obstructive hydrocephalus, and secondary esodeviation because of elevated intracranial pressure. Also had been seen with cases of benign intracranial hypertension. And I remember one patient, she was I had seen her in King Khalid University Hospital, where she had esotropia, and she was treated as with a refractive error of +2.5, and she was following for around 6 months. I don't know if the first physician saw the fundus or not, but when I saw the fundus, I saw that the disc margins were not clear. So I used 90 lens, and I found that the patient is having optic disc edema. And I think Dr. Abdullah Musa know the patient well. And I referred her to emergency. We did MRI, and there was nothing in the MRI. But when they did open pressure through lumbar puncture, it was high. Even what strikes me that she was complaining of headache, she was having nausea with the esotropia, but no one had examined her fundus carefully. She was started in acetazolamide, and she is doing fine now. The association of acute acquired comitant esotropia with corpus callosum gliomas is there also, and clinical signs might be absent in any other part of the body. Coexisting or underlying neurological pathologies were present in 6.4% of acute acquired comitant esotropia in one study. And Liu et al. Found that 40% of cases of esotropia related to underlying brain insult was comitant. So 60% incommitant and 40% were committant. So if you see a patient with incommittant strabismus, you might think of space-occupying lesion in your evaluation. But if you see committant strabismus, also he might have space-occupying lesion. Williams and Hyatt describe 6 children over 9 years, and this is very nice, by the way, finding. They describe it over 6 children over 9 years with the brain tumors, and this is what they found. None of those patients initially presented with anything other than acute comitant esotropia. Neurological examinations and imaging were obtained only, so they treated them as if they were having esotropia only. And they didn't image them, and they didn't refer them to a neurologist, except after nystagmus developed in 3 patients, and facial paresis developed in 1 patient, and the other 2 were scanned because the parents were insisting. The parents were insisting, doctor, we feel that our children are not well developed, and we feel that they are maldeveloped. So they scanned them, and they found 4 were found to have cerebellar astrocytomas, and cerebellar medulloblastoma was found in 1, and pontine glaucoma were found in the other 1. Cherry malformation also had been associated with comitant esotropia. And for me, I review it, the types are 1 to 4, the 3rd and 4th type are fatal and it's not compatible with life, but type 1 and 2 are compatible with life. And it's a spectrum of congenital hindbrain abnormalities affecting the structural relationship between the cerebellum, brainstem, and the upper cervical cord, and the bony cranial base. And the cherry 1 malformation can cause acute onset of diplopia, headache, comitant esotropia, nystagmus, A pattern, or other neurological signs. This is the most important thing. Even in hydrocephalus, the most important thing is to control the pressure before you operate the patient. So if you have a patient with hydrocephalus or with a cherry malformation, first, the appropriate sequence of treatment should be first suboccipital decompression, then strabismus surgery if spontaneous realignment does not occur. So first, control the intracranial pressure, then do the operation. Who's from شقرة؟ في أحد من شقرة؟ حد يعرف الصورة دي من وين؟ This is from Shager. Very nice. I like the way of treating plants. They didn't like it to lay on the floor, so they put something to support. how would you evaluate a patient who came to you with acute comitant esotropia? First, obtain a careful history, including any previous management, glasses, patching, surgical, any strabismus before. Did the esotropia occur suddenly, or it had been progressing? It was small, then with time it progressed? Presence of diplopia, and is it worse at a distance or at near? Is it worse when the patient looks in a certain direction? Obtain a careful examination, including ocular motility, ocular alignment. When possible, check for fusion and stereo acuity, and cycloplegic refraction. And we shouldn't forget to examine the fundus, and it's a red flag to miss the fundus examination. This is the American Academy of Ophthalmology preferred practice pattern. Many of us or colleagues in residency were asking upon what you give the glasses in certain cases or not. So this is the American Academy of Ophthalmology. The threshold is more than 2.5 in infants, more than 2 in 1 to 2 years, and more than 1.5 in children 2 to 3 years of age. If the esotropia does not respond to spectacle correction, a second cycloplegic refraction should be done to make sure that you are not missing or there is no hidden hyperopia. Sometimes we ask to give atropine for 3 nights before. When not to do imaging. I started by when not when to do. We will have when to do imaging. When not to do imaging, through the literature, when I review it, they said when the strabismus is clearly caused by uncorrected or undercorrected hyperopia or significant uncorrected myopia. If there is a high accommodative convergence accommodation ratio, untreated anisometropic amblyopia that results in decompensation in a child with a pre-existing microtropia or esophoria where patching precipitate manifest squint. This is in absence of any other symptoms. If you have any other symptoms, no, you should deal with the patient according to the symptoms. If there is a neurological symptoms or there is other findings in the fundus, you should deal accordingly. So when to do imaging? We will have a couple of slides. Lyons said there is no single clinical sign can reliably indicate the rare patients harboring a tumor, but a high index of suspicion should be maintained. The absence of expected findings such as hypermetropia or fusion potential also ring a bell. The presence of atypical features or presence of neurological signs. Pouch and findings, they said, or when they did their study, they found 4 significant risk factors for intracranial disease. And these factors are larger esodiviation at distance, recurrence of the acute acquired comitant esotropia, neurosigns like papillary edema, older age of onset more than 6 years. Intracranial disease include hydrocephalus, pontine, and thalamic glioma. Findings suggest acute acquired comitant esotropia of childhood to be differentiated from that one of adulthood. So we have different between adulthood and children in these factors. This is a crowd slide, but it summarizes all the findings that you should image the patient if you find it. Let's say if the age is more than 5 years, if there is abduction deficit, so it's not anymore comitant. If there is diplopia at presentation, distance angle larger than near angle, severe headache, gait disturbance, facial numbness or paresis, acquired nystagmus, optic disc edema, reduced acuity or color vision, abnormalities of pupil responses, failure to regain stereopsis after prism adaptation or surgical correction. This is late. Everyone knows this picture, but you might not know the camera that I used to get this picture. Who can tell me what camera? This is a mobile camera, but this is G5 mobile camera. It's having a wide angle, which is nice, so you can have 120 angle. I got it from Mecca, me myself. Let's see 2 examples, very nice examples. Lyons did mention it in his paper. The first one, a 4-year girl, noticed to have to close or cover one eye, and she had complained of seeing double. Left eye was noted to turn in. General health was good, and no headache, and no family history of strabismus. Her vision was 20/20. She was having comitant strabismus of 35. Full abduction of each eye with no nystagmus. Synaptophore testing showed left suppression on cycloplegic refraction. There was no significant refraction. The optic disc was normal. Neurological examination was normal. Who will do imaging for this patient? Anyone will do imaging with these findings? No one? Dr. Muhammad, you'll do? So we have hands now raising. Okay. Let's see what he found. Her MRI showed astrocytoma. See, even though with the description that I give you, she had astrocytoma. And by the way, they didn't find it because they were believing to do MRI, but they were conducting a study. Every patient with acute comitant esotropia coming to the facility, they were going to undergo for MRI. So she underwent total neurosurgical excision of a low-grade astrocytoma. Several weeks she had been operated for strabismus surgery, and the diagnosis was acute esotropia associated with posterior fossa tumor. As I said, 50% of posterior fossa tumor will present with acute acquired comitant esotropia. Let's see the other case. 6-year boy, he kept one eye closed much of the time because of diplopia. He was in good health with no headache or history of trauma. There was a family history of myopia, but no strabismus in the family. Vision was 20/20, angle 20, comitant, right eye at near and at distance, 100 seconds of arc, eye movements including abduction was full, the cycloplegic refraction was not significant, the optic disc was normal. Who will do imaging in this patient? More hands raised now. Actually, this patient, MRI brain was normal. What I think was the cause of doing MRI if I'm in the situation? I think the age here was not in the favor of doing MRI, but the diplopia was there. This is the only thing. If I go for imaging, I will go because of diplopia and the acute onset of the pathology. The other one, it's more than 6 years. But if you see there's no headache, there's no history of trauma, there's and the angle is not a large angle, but it doesn't matter if you do MRI and if you feel that this patient might have something. In summary, non-accommodative comitant esotropia may be not as common as what we thought before. Once it was thought almost, now non-accommodative comitant esotropia may not be as uncommon in children as once thought, almost twice as frequent as infantile esotropia. As I show you from the literature review, it's accounting for as twice as infantile esotropia. Comitance of the esotropia and horizontal gaze may provide some reassurance that underlying central nervous system lesion is absent, but no mean that it will guarantee it. Ophthalmologist must rely on his or her clinical acumen and patient's history to determine the need for neuroimaging. And the disease can occur in cases of Arnold-Chiari malformation, hydrocephalus, and central nervous system tumors, even before any other presenting signs, such as downbeat nystagmus or papillary edema. Even if acute acquired comitant esotropia is typically benign, it is important to exclude tumors of the cerebellum, especially in patients with diplopia and headache or nystagmus, tumors in the bones, tumors in the corpus callosum and the hypothalamic region. The cerebellum, which we are not thinking that it's related much to the vision or to the motility, the cerebellum as a part of extrapyramidal system may play an important role in maintaining normal ocular alignment. Those who have knowledge do not predict. Those who predict do not have knowledge. This is a Chinese philosopher 600 years before surgery. Thank you.
please go back to the slide where you explained the cases shouldn't, no need for imaging? This one. You mentioned in the first one, in the cases where significant uncorrected myopia. I think we have many patients presented in the clinic with over minus glasses, which is presented with acute comitant esotropia. So mostly optometrists, they like to give the patient over minus, and the patients, they like to be over minus. So that's why they presented with acute comitant esotropia. So it's very important to be sure if the patient is myopia to rule out over minus.
Yeah, this is what I mentioned in the classification of non-accommodative esotropia. As we said, we have 3 classifications, and the third one is the Olszewski type, is associated myopic patients, and most of them, they are over minus. And as you know, the myopes like more. They like more minus. And kids nowadays, they have a lot of near work tasks. So most of the time, they will come to you with the accommodation. So when you examine them, you will find them myope, -2, -3, -4. And sometimes if you give the glasses according to your dry refraction, you are over correcting him. Dr. Leon, Prof. Leon, also mentioned in one of his case series of these cases that he mentioned, one of the children who was treated as myope, and when they dilated him, he was plano. And the glasses that he was given induced esotropia.
Thank you, Ismael. Interesting topic that sometimes seen frequent, but maybe missed. For me, the only situation that I do not order imaging is 2 things. If the child is, the history is clear that is what started early, like in infancy, okay? And if the child have hyperopia, like +2, +3 or more, then I deal with it as possibly a cumulative thing and I can treat with it. But any child who has acquired strabismus and there is no hyperopia, I image them usually. Maybe we are in KKH, so we are having easily accessible to the MRI, but I don't want to miss any child with
do you look to the comitancy, Dr. Mohammed, or regardless of comitant and comitant strabismus?
Regardless, if there is uncomitant, it's clear that it needs imaging. But regardless, especially that the kids usually may be difficult to appreciate all the incompetence.
Again, I want to emphasize the examination of the fundus. If you take only 30 seconds to see the fundus, you might find that the child or the patient is having neurological sign. Sometimes we do refraction and overcome the examination of the fundus. I encountered 2 cases. One of them had been referred here to Dr. Mohammed and imaged, and was having atriovenous malformation, and referred nowadays to King Faisal to treat. And the other one was the one, actually her brother is an oncologist, and she was following elsewhere for around 6 months, and no one had examined the fundus, and no one had seen that the disc is edematous. تفضل بروف.
يعطيك العافية دكتور إسماعيل. I have a question regarding decompensated commutative esotropia. How you handle this? Do you go to surgery, or you need to image to investigate the cause, or?
If, as I said, if you have any other, because it might be also something hidden, neurological. It doesn't guarantee if the patient was accommodative, then he developed a non-accommodative component, that he didn't develop central nervous system. If there are symptoms, if there are signs, you should image. But we are facing such a condition, and the only treatment, if you roll out everything else, is surgery. You do surgery. And most likely they will end with a good results.
And my other question, how do you define acute? Is it like within a day, a week, 6 weeks, or what the literature?
Well, in the literature they didn't specify what is the time fact, but I think if something acute within weeks, something within weeks, or 2 to 3 months, not more than this.
Maybe the acute differentiate from something that is present from the ear,
Mm.
so like congenital or something acute that acquired.
No, they mentioned acquired is different from acute. Acquired non-accommodative is the like umbrella, and this is under the acute. Acquired is something little less than the acquired non-accommodative. تفضل دكتور.
Thank you, Dr. Ismail. I just want to ask regarding the treatment of those patients. Can we do it like partially accommodative esotropia? I think they have a memory of fusion, and can we start with the Botox first, then surgery?
No, as I said, first treat the underlying cause. Don't go and treat if a patient is having central nervous system insult. Treat first the central nervous system pathology. If it was high intracranial pressure, benign, treat it either medically or if they need surgically. If it's Arnold-Cady malformation, through decompression. If it's tumor, through excision. Then, because the patient might be weaned from the esotropia or treated from esotropia without interfering you by surgery. After, if he's having residual or having esotropia after the treatment, you might go and treat accordingly.
Thank you. And the other case, just I want to ask, the other case, the first case you mentioned with the low-grade astrocytoma, the disc was normal. Is it was a bilateral 6-nerve paresis?
I didn't mention sixth nerve paresis.
It's only
The
related
one,
to the...
there was full ocular motility.
Yeah.
There was no paresis. This is the striking. And as I said, the astrocytoma or posterior fossa tumors, if it will have 50% of those cases will not have anything except esotropia.
Thank you, Dr. Ismail, for lecture. Could they have paresis, but it's difficult to assess saccade pursuit in children?
Could be, because as I said, one of the explanations, they said it might start as paresis, then it was spread over. Or the patient had recovered from the paresis. Then you see him, he presented to you after he was covered from the paresis. It might start as incomitant, but when he presented to you, he presented as comitant strabisms. Thank you. I think we can end this talk.